Good evening. Welcome to SENADHIPAN Education Foundation. Never stop your learning because life never stops teaching. This is the quote by Einstein. A short history about the SENADHIPAN Education Foundation. Actually, it was initiated in 2012 Jan at Taj Vivanda, Trivandrum. It was inaugurated by the world-renowned colorectal surgeon, Dr. Sion Han Kim. And then he visited our hospital. Since then, we are having contact classes like this in our hospital. Because of the COVID, we started online programs. And the logo was released by Dr. Palanivelu in July 2020.
Over to you, sir.
Yeah. Thank you, Risha, and thank you, Baiju, for inviting me to be today's.
And then onwards, we used to have online classes, live surgeries, online lectures with eminent faculties, and they used to do certificate courses. We had eminent faculties from outside India also. Actually, Professor Joel Leroy gave a wonderful lecture 2 weeks before in SENADHIPAN Education Foundation. We have all these stalwarts in our platform. And we have got very good global acceptance. Last meeting, actually, 790 people logged in from different parts of the world. We have got good acceptance. Actually, we have 2 WhatsApp groups of surgeons, 256 each in WhatsApp, and we have got a Facebook group of 533 members as of now. Today, we have 2 eminent people to give you a lecture on hepatocellular carcinoma. The first is actually our speaker himself, Dr. Chirag Desai. He is the Chief Consultant and Program Director of GISPB and liver transplant at Apollo, Ahmedabad. He took his FRCS from UK. He has got FRCS in Edinburgh, FRCS Glasgow. He worked for a few years in Royal London Hospital and Royal Free Hospital, London. He had the RCS traveling, Royal College of Surgeons and Physicians traveling fellowship to Asan, Korea, which is the mecca of liver transplants. And he is the honorable SPB surgeon and liver transplant surgeon to the governor of Gujarat. He is an examiner to the Royal College. He has got Times of India Award for liver transplantation. He came in Indian Book of Records by mobilizing almost more than 12,000 plus people for organ donation. Congratulations to Chirag. Presently, he is the honorary treasurer of ISPBA India. Welcome, Dr. Chirag, to this show. And welcome Dr. Naimish Mehta also as the moderator. You must be wondering, seeing his credentials. He is the co-chairman of GI Surgery Department, Sir Ganga Hospital, Delhi. As of now, he has done more than 1,000 liver transplant. And he has done the world's first LDLT with the open heart surgery in a child. He is the one who has done the first living donor intestinal transplant in India. He has done donor hepatectomy in situs inversus and has done dual lobe liver transplant in India. Welcome, Dr. Naimish Mehta, to this show. Before starting the show, let me invite you all to the next show, next Sunday, 8 p.m. It's none other than by Jog Diaz, who from Colombia. He is supposed to be the proponent of enhanced extraperitoneal view, and he is the one who has proposed enhanced view for extraperitoneal approach. He'll be talking about extraperitoneal space, the last frontier. I request all the participants to mute their mic on entry. If possible, kindly acknowledge your name by renaming your device. Participants logging from outside India are requested to reveal their identity in the chat box so that the host can acknowledge them. Raise your hand if you want to intervene between the talk or session. Everybody will be given permission to unmute their mic if they want to speak something after the session. If you are on a portable device, please mute your audio and hide your video. Please hide your video while the speaker or the moderator is presenting. Then after you can open your video after the presentation. This is to enhance the visibility and the clarity of the videos the speaker is going to show. Thank you all. Over to the moderator, Dr. Naimish Mehta.
Thank you very much for such nice introduction, Dr. SENADHIPAN. And let's not waste our time and let's start the discussion with the HCC Demystified. There are a lot of things. There'll be a lot of questions coming up from the participants, and as already pointed out, we'll be taking each and every questions and trying to answer all those. So Dr. Chirag, who is a good colleague of ours, will be taking over from here. Dr. Chirag, we welcome you and start your lecture, please.
Thank you, SENADHIPAN Foundation, Dr. Baiju, Dr. Naimish, and all the participants for sparing time and trying to be here. So the topic of my presentation is hepatocellular carcinoma demystified. So I'm going to address these issues: diagnosis, screening, staging, treatment options, resection, liver transplant in HCC, treatment of advanced liver tumors, treatment of tumors with presence of portal vein or hepatic vein thrombosis, tumor thrombosis, liver-directed therapies, and then a few slides on systemic therapy. And then the case-based selection of the treatment option. So as we all know, hepatocellular carcinoma is one of the most common malignancy worldwide. Annual incidence is very high. It is as high as more than 1 million cases every year. There is significant male preponderance. 90% of the primary cancers of liver are hepatocellular carcinoma. And usually hepatocellular carcinoma occurs in the background of chronic liver disease and cirrhosis. It is more common in Eastern Asia and Sub-Saharan Africa. HCV, HBV, and hemochromatosis are very common as a etiology. However, the alcohol abuse, non-alcoholic steatohepatitis, metabolic liver disease, and some aflatoxin are also responsible for the causation of hepatocellular carcinoma. Now, if we talk about the pathology of this tumor, the small HCCs are defined as those which are smaller than 2 centimeters, and the large ones are the ones which are more than 10 centimeters. HCC has a very intense tendency to spread locally, and as a part of this, it involves the local vessels, especially portal vein, and in some cases, hepatic veins. Once the portal vein becomes involved, the fragments of the tumor spreads within the liver as well as hematogenously, and that leads to aggressive behavior and spread of the tumor, and that all defines the ultimate outcome of the patient. Invasion of hepatic vein is less frequent, but when it occurs, it can lead to the thrombus extending into the IVC as well as atrium. Extension can also occur into the biliary tree and can lead to hemophilia or obstructive jaundice. Metastasis is not very uncommon. The common sites of metastasis is hilar nodes, lungs. However, it is also known to spread to bones, brain, meninges, adrenal, kidney, pancreas. These are the usual sites where it can spread, and time and again we find it. Dysplastic nodules in a cirrhotic liver and hepatic adenoma are the pre-malignant lesion, and it has a proven adenoma carcinoma sequence. When we take the history of this patient, it's very important that we take the past history of hepatitis, jaundice, blood transfusion, drug abuse, past surgery, any family history of liver disease or hepatitis, and use of any sex hormones or carcinogenic drugs. Now, how these tumors present to us? Many times these tumors are incidentally identified while active surveillance or while doing the investigations for something completely unrelated. And these tumors are asymptomatic. And many times they are identified as a part of screening also. So when the tumors are small, it is asymptomatic. However, when it becomes symptomatic, the common symptoms are very general symptoms. They are not specific for a tumor. And hence, when any of the symptoms is present, then one has to investigate these patients properly and make sure that if the HCC is present, then it is picked up early in the course of the disease. So the common symptoms are abdominal pain, fullness, weight loss, anorexia, even nausea, weakness, pyrexia of unknown origin. If the tumor is large, then it can lead to a palpable liver or a palpable lump. There may be jaundice, sudden decompensation or a weight loss in a cirrhotic patient. At times is suggestive of hepatocellular carcinoma and needs repeat imaging. At times, patients present with complications and it is in the form of hemoperitoneum, which could be either because of the rupture of the tumor or because of the bleeding after needle biopsy. Jaundice is present in 10 to 30% of the cases, and the common causes of jaundice is underlying liver disease, obstruction or infiltration of the bile duct, obstruction of the common hepatic duct at the porta because of the large tumor itself, or at times the lymph node, and blood within the biliary tree leading to hemophilia and jaundice. Hematemesis may be the presenting symptom at times because of the underlying portal hypertension or sudden portal vein involvement because of extension of the tumor into the portal vein. At times, patients present with either bone pain or respiratory symptoms, and which are the indicative of metastasis. And when we examine these patients, again, if you're not very careful, it is not clinically evident, and it is usually identified as a result of investigations. When we evaluate these patients, the blood tests, then tumor markers, imaging modalities, and very rarely biopsy is used for the evaluation. When you do the hemogram, these patients may have thrombocytopenia or neutropenia, and which may be indicative of hypersplenism because of underlying liver disease and portal hypertension. Liver function tests tend to reflect either the underlying liver disease, but if even in a non-cirrhotic liver, if there is a large tumor present, it just because of the presence of a large space-occupying lesion, there may be a rise in alkaline phosphatase or gamma GT. And it is very important that we carefully interpret this abnormal liver function tests. Hepatitis serology and other tests are done to find out the etiology of cirrhosis if the cirrhosis is present. Now, a lot has been talked about and research about tumor markers so far. The most commonly used in clinical practice is alpha-fetoprotein. It is elevated in approximately about 50 to 70% of the cases, suggesting that in 30% of the cases, in spite of having a tumor, you may not have a raised alpha-fetoprotein. At the same time, even a small tumor can have a very high alpha-fetoprotein. In absence of tumor, just the chronic active hepatitis can also lead to rise in alpha-fetoprotein. It is more effective in tumors where the size of the tumor is more than 5 centimeters. It is more commonly associated and raised in case of undifferentiated or poorly differentiated tumors. The more the differentiated is the tumor, the less is the possibility of raised alpha-fetoprotein, though this is also not absolutely true. Then the another tumor marker, which is the fraction of alpha-fetoprotein, is at time used, but this is not widely available in most labs. And this carboxyprothrombin is another tumor marker, which is helpful. And at times, some centers use these in combination. So alpha-fetoprotein is raised in presence of hepatocellular carcinoma, and its presence and its level depends on the extent of differentiation of this tumor. So undifferentiated HCCs have higher incidence and higher levels of same size tumor. Differentiated tumors have lower level of alpha-fetoprotein for the same size. However, in highly differentiated tumors or tumors like fibrolamellar HCCs, because it is a very well differentiated tumors, there may be even serum negativity, or it is only weakly positive. Alpha-fetoprotein has no diagnostic value, but it has a prognostic value. However, it has some diagnostic value when it is used with classical imaging features. So what are the imaging modalities that we use for diagnosis of hepatocellular carcinoma? As we all use, ultrasonography is the first line investigation. It can identify tumor as small as 1 centimeter. It also identifies and gives information about the associated biliary and vascular infiltration. Indirect evidence of portal hypertension is also evident. The typical hepatocellular carcinoma is seen on sonography as echoic or hypoechogenous mosaic pattern, and hypoechoic border around it suggests the pseudocapsule or capsule. The Doppler feature of the ultrasonography helps to identify the portal venous flow and whether the portal vein is compressed or obstructed. The most important radiological investigation in the diagnosis, staging, and overall planning of treatment of hepatocellular carcinoma is a triple phase CT scan. This triple phase word is very important. It is not just contrast enhanced, but the properly done sequences are very important. So for detecting very small HCC, again, the triple phase CT scan is very, very important. Now, this is something which is very widely available in most of the good liver centers. The specific features are early uptake, so which is known as early arterial enhancement in the arterial phase. There is enhanced pseudocapsule. Then vascular invasion and arterioportal fistula is also identified on this contrast scans. Presence or absence of portal vein thrombosis also identified, and the nature of that thrombus is also characterized with the help of a good sequence contrast CT scan. The CT scan also helps by detecting associated cirrhosis, extrahepatic spread, measurement of the liver volume, measurement of the future residual liver volume, and CT lipiodol shows retained lipiodol in the lesion for up to 1 to 4 weeks after injection of the lipiodol contrast. So arterial enhancement, rapid washout on the portal venous phase, and then delayed peripheral enhancement of the capsulation is the classical feature of hepatocellular carcinoma on triple phase CT scan. So this is the tumor with classical arterial enhancement. You can also see very irregular margin of the liver, and this is a cirrhotic liver and large spleen, though there are not many collaterals, and there is a large mass in the right lobe of the liver. So these are the 4 phases. So plain scan, arterial scan, portal phase, and equilibrium scan. You can see this is how the tumor is seen on plain scan. This is arterial enhancement, washout, and this is the appearance on the equilibrium phase. And then late, there is enhanced capsule seen on the CT scan. MRI is helpful when the CT scan has equivocal features. On MRI scan, hepatocellular carcinoma is seen as hypointense in T1 images and hyperintense in T2 images. It also shows a very classic mosaic pattern and a presence of a capsule. And gadolinium enhanced images are must. So this is the classical appearance on MRI. This is hyperintense on T1 images, hypointense on T2 images, and this is the classical peripherally enhanced capsule. So this appearance is very classical of hepatocellular carcinoma, and there is no need to do the biopsy to confirm the nature of the lesion. FDG PET, it is not very sensitive and it's not routinely used. And when used, it can influence the overall treatment plan in less than 1/3 of the cases. When used and it is picked up by a tumor, then it can identify the presence of extrahepatic metastasis and can change the plan of management. Now, this is something which is very important and is a development in the last few years. It's called LIREG. So it's a liver imaging reporting and data system. It is created to standardize the reporting of the data, and that is necessary to apply the consistent terminology, to interpret it consistently, to describe it consistently, so that different studies and trials and case series can be compared. It facilitates the quality assurance and research. And hence, the CT MRI LIREDs and US ultrasound LIREDs have been incorporated in hepatocellular carcinoma guidelines by American Association of Study of Liver Disease as well. So what is this? So depending on the features and the certainty about the diagnosis, if it is definitely benign, it is LR1, probably benign LR2, intermediate LR3, probably FCC LR4, similarly like this. Then if there are features suggestive of malignant lesion other than HCC, then it is known as LRM. And if it is already treated and it's a follow-up scan, it's LR treated. So these are the terminologies used, and hence we should also now use them when we are piling up our data and should include in our records. The commonest differential diagnosis is dysplastic nodules and cirrhotics and hepatic adenoma. Hepatic adenoma is both of them are precancerous. Hepatic adenoma can also look like hepatocellular carcinoma, as we can see in this, and it can be resected without biopsy. By doing biopsy, you are doing disservice to the patient, and there's no need to confirm the diagnosis if the radiological appearance is very classical and the patient is fit and easily resectable lesion. So what is the role of biopsy in the current day and age in presence of hepatocellular carcinoma? So obviously a patient who is a candidate for surgery is a straightforward case. There is no confusion about the diagnosis. The classical imaging modalities are there. Then there is no need to do biopsy. Go ahead with the surgery straight away. But if the diagnosis is doubtful, features are equivocal, if you are not going to operate the patient, you're going to do palliative care or going to do some non-operative treatment option, then the biopsy may be needed. And this is a situation where percutaneous biopsy has some role. Then biopsy of the non-tumorous part of the liver is at times done if there is a suspicion about the quality of the residual liver or the quality of future remnant liver. However, with the availability of good imaging and elastography and all, the possibility and need for this has reduced. However, this is still used at times in very selected cases for specific purpose in some centers. The biopsy is not done routinely because it is not without complication. There is a possibility of hemorrhage, pain, false positive or false negative report. it may be difficult to target a very small lesion, especially if it is very deep-seated. It can increase the possibility of a vascular spread if it is very aggressive malignancy. And there is a theoretical 2 to 4% of risk of needle track seedling of the tumor. So if the arterial hypervascularity and the washout in any lesion more than 1 centimeter is easily seen, biopsy is not needed. However, if the images are equivocal, then biopsy may help you to prove the diagnosis. There are different diagnostic criteria for HCC. So in radiological criteria, if the two different imaging have conclusive and very characteristic appearances of hepatocellular carcinoma, you don't need anything else. If one imaging modality has classical appearance and the alpha fetoprotein is more than 400, again, you don't need anything else to confirm the diagnosis. But when any of this is not there and the lesion is very small, you want to characterize that lesion, in that case you do the biopsy, and then you have a cytohistological criteria. So who are the patients who need screening, who should be subjected to screening? So in Japanese screening program, where the incidence of or the prevalence of HCC in the community is very high, 50% of the tumor which were picked up were very small, 80% are unifocal and easily operable, and more than 1% of the population screen had a positive outcome. While Italian study had, in contrary, very small tumors identified in less than 30% cases, and fewer of these cases were resectable. Hence, there was a dilemma whether screening is really worth it or not. However, in most centers, it is a good practice to follow a high-risk population, all the cirrhotics, all the hepatitis B, C, or hemochromatosis patients, or patients with significant NASH, to follow them periodically with the help of sonography 6 monthly, plus or minus addition of alpha fetoprotein in selected cases if there is suspicion, and that helps us in identify tumors in the early stage. So how do you stage these patients? It's very important to stage any cancer patient before the treatment is planned. So as I said, the triple phase CT scan with volumetry, chest CT, bone scan, tumor markers, and cardiopulmonary assessment to assess the fitness of the patient. Once this is done, there are various staging systems, and there are so many systems because none of them is foolproof. There is too much of there are too many permutation combination, too many factors to be taken into account because of cirrhosis as well as tumor. So both the variables have contribution. There is heterogeneous population around the world, and hence different part of the world use different systems. However, the most commonly used staging system, which is very helpful for the current treatment planning also, is BCLC staging system. So as we can see here, as the tumor volume and the burden of the tumor increases, and the way it is located and situation, and whether it is confined to liver and it has gone beyond, or whether there is vascular involvement or not, it is categorized into stage 0, stage A to 3, which is early to advanced, and stage D, which is an end stage. And this decides the survival. So this is survival more than 36 months. Here it is down to 16 months. And when you come here, it is very few months. And eventually this is almost pre-morbid. So these are the various treatment options according to the stage, and we'll talk about this later. So for planning any treatment modalities in any cancer, the most important thing is to discuss all the facts about that patient in a multidisciplinary tumor board, which is composed of specialists from different specialties. So the current treatment options that we have is surgery in form of either resection or in selected patient liver transplantation, local regional treatment, which is also known as liver-directed therapy, which is either in form of radiofrequency ablation or other ablation methods, or even very rarely percutaneous injection of alcohol, transarterial chemoembolization, transarterial radioembolization, SRBT, that's radiotherapy, SBRT, and systemic therapy. So how do we assess the resectability of this patient? So there are tumor factors to be taken into account, and that is number of lesions, size of the tumor, location of the lesion, extrahepatic disease present or not, and vascular involvement present or not. And if yes, what is the extent of vascular involvement? Then there are liver factors, which is what is the status of the underlying liver function, what is the volumetry, and what is the quality and the volume of future liver remnant. Patient factor in terms of comorbidities, and logistic factors in terms of facility and expertise available. So in each one of these factors is very, very important when you are trying to decide the resectability, and not only whether patient is resectable or not, but what is the right time for the surgery and what is the extent of the surgery. Apart from this, even the Child-Pugh score is also very important, because it gives you the quality of the underlying liver function, and that will decide what extent of surgery this patient will tolerate, or whether this patient will tolerate surgical intervention or not. So qualitative assessment and quantitative assessment of the liver both are important. The ideal residual functional liver volume should be at least 30% in absence of cirrhosis, and in presence of cirrhosis, ideally it should be close to 40%. And if you try to err on the side of lower residual liver volume, then the incidence of post-operative complication is high. Surgical excision is a reliable and the most effective and most possible curative option for the treatment of hepatocellular carcinoma. The goal is to remove the whole tumor burden with at least 1 centimeter, if possible, of the surrounding tumor tumor margin, margin of the normal liver. So there are two types of liver resection. One is non-anatomical wedge resection and anatomical resection. In presence of cirrhosis, if you try to do major resection, the mortality could be as high as 5 to 10%. But if you select the extent of the surgery and select the patient properly, then this mortality can go down to as low as 1 to 2%, which is very good. And this is what is the case in most of the good high volume centers these days. If the right patients are selected and the surgery is done with the right technique, resection can be done without blood transfusion also. Now, liver resection in presence of cirrhosis is a slightly difficult proposition and slightly more morbid, because there is higher incidence of bleeding secondary to coagulopathy or portal hypertension. There is higher incidence of liver failure, because the quality of the residual liver volume is poor and the ability of that liver to regenerate is also poor. So this patient at times may take time to recover in the post-operative period. Now, when we decide to operate, we have selected a patient for surgery, we have decided the extent of surgery. Now, there are 3 ways of doing surgery, and that is conventional open surgery, laparoscopic surgery, robotic surgery. Oncologically, they all are same. The only difference is the extent of and the method of removing the tumor. Obviously, the recovery would be better if it is done through minimally access route. However, it is not easy and not everybody's cup of cake. Everybody is not Dr. SENADHIPAN. However, if it is done by an expert person, the results are very good in the laparoscopic and robotic surgery. And later, Dr. Naimish is going to show a video on that also. So once the surgery is done, if you compare the anatomical and non-anatomical resection, if you see here for the overall survival as well as disease-free survival, because the anatomical resection takes care of the pedicle of that particular segment, it is oncologically better, and hence the overall survival and disease-free survival are both better in anatomical surgery. And hence, whenever possible, anatomical resection is preferred over just non-anatomical wedge resection. Now, to make surgery safer and possible in those patients where otherwise surgery is not possible, there are a few agents which are used, and that is intraoperative ultrasound to guide you during surgery, preoperative portal vein occlusion to increase the volume of the future liver remnant. However, in diabetics, cirrhotic, and in male patient, the response of hypertrophy following portal vein embolization may not be good. Portal vein embolization is more commonly used before surgery in case of colorectal liver mets or in cholangiocarcinoma, only occasionally used in case of hepatocellular carcinoma. The use of Pringle liberally reduces the bleeding and makes surgery quick at times and less morbid. It is not mandatory to use it, but it is something which can be really helpful. When used, 15 minutes of Pringles on, 5 minutes off, and such 4 times can be used safely, even in cirrhotics. At times in a patient with bulky tumor or borderline resectable, you may try liver-directed therapies to downstage the tumor, make it resectable. By then, you will also know the biology and aggressiveness of the tumor, and in suitable patients, then you go and do the surgery and try to achieve better outcome, better survival, and good result. Liver resection is an optimal treatment when possible. It's mainstay of the treatment as far as the cure is concerned. Patient tends to be highly selected. Patients frequently have underlying liver disease, and hence you have to plan and select these patients very carefully. So in a solitary tumor, in absence of vascular invasion, in absence of significant portal hypertension, with well-preserved liver function, liver resection has very good result, and 5-year survival could be as high as 90%. However, the recurrence is the problem with all the treatment options in hepatocellular carcinoma, and it because of the underlying precancerous cirrhotic liver. So this is the example of a tumor of the left lobe of the liver, and this is the tumor at the time of operation. This patient had left hepatectomy, and so what is the role of surgery in advanced hepatocellular carcinoma? So what is advanced hepatocellular carcinoma? Any tumor which is larger than 10 centimeter with significant vascular invasion, local invasion of the diaphragm, extrahepatic metastasis, poor underlying liver function, and multicentric HCC. These are advanced tumors. So these first 3 are amenable to surgical treatment. The other 3 are not. So this is the example of right hepatectomy in a large HCC on the right side. So large HCCs are important because they are associated with higher incidence of vascular invasion and higher incidence of metastasis. However, all large HCCs are not aggressive, and hence even a large HCC can potentially be cured after large resection. And hence the good resection and negative margins are very important. 5-year overall survival rate of more than 50% may be achieved even in a very large tumor. Post-operative disease-free survival and overall survivals are similar between patients with large and small HCC, provided the margins are negative and there is no vascular involvement. Prognosis depends on vascular infiltration, condition of the underlying liver, presence of satellite nodules away from the tumor within the specimen, which are otherwise not seen on imaging, but they are identified on the histological specimen. And multicentricity, again, if there is one large tumor and 2 or 3 small lesions, the 2 or 3 small lesions probably has worse prognosis than one large lesion. Negative margin, as I have been saying, is very, very important. When a Japanese cohort was studied for large HCC, the patient who underwent surgery had 1, 2, and 3 year overall survival was as high as 70, 60, and 50%, which is very good. Hence, surgery for large HCC is feasible, safe, and better than TACE when the liver function is good. So this is the comparison of TACE versus surgery in large HCC. So if you do a successful surgery, TACE has inferior result compared to surgery in large lesions. So when surgery is not feasible, obviously the TACE or the chemoembolization is the option we are left with. However, when surgery is feasible, surgery is definitely the first option. This is a large tumor in right lobe of liver occupying segment 5, 6, 7, 8. This is the resected specimen, and this is the end result. So the liver is non-cirrhotic, had some fibrosis, and the patient had good recovery. Now, HCC adherent to the diaphragm, the next example which I'm going to show you is a case, 55-year-old male, hepatitis B positive, on antiviral treatment with viral count under control, normal liver function test, mass was present in segment 5 and 6, but the diaphragm was involved. Local contiguous excision of the diaphragm gives good survival, which is equivalent to those patients who did not have involvement of the diaphragm. So the negative margin on the side of the diaphragm is also very important. So this is the CT scan picture. So it is the tumor in segment 5 and 6. This is, you can see, this is a non-cirrhotic liver. The part of the diaphragm has been removed along with the separated. Here you can see the part of the diaphragm, and the diaphragm was then repaired with mesh. And this is the cut surface. Another example of advanced liver tumor or advanced HCC is presence of portal vein tumor thrombus. Now, in presence of hepatocellular carcinoma and cirrhosis, portal vein thrombosis could be either because of thrombosis due to cirrhosis, which is not associated with tumor, and thrombosis because of the tumor. So these are two different things. So one is called bland thrombosis or benign thrombus, other is the malignant thrombus. So this was the review which is recently published, and it suggests that 35 to 50% cases have some form of portal vein thrombosis present, either microscopic or macroscopic, maybe the peripheral branch or the central branch. It represents a very significant negative prognostic factor. The median survival comes down if the major vessel is involved to only few months if there is no treatment done. However, now there are various treatment options available, and because of that, the survival as high as 5 months to 5 years has been achieved, and thus there is extreme variability and there is whole spectrum of HCC with portal vein thrombosis. And why there is such a spectrum? Because there is a different stage of portal vein thrombosis. So if peripheral branch is involved, the prognosis is better, and then the second order branch, first order branch, and the main portal vein. So these are the various classifications, and they are classified as VP 1, 2, 3, 4. And similarly, classification for hepatic veins. Now, the aim, whenever we see the presence of a thrombosis in portal vein, or whenever we see hepatocellular carcinoma, first to determine whether there is present or not portal vein thrombosis. And when there is portal vein thrombosis present, whether it is benign thrombus or a tumor thrombus. So to determine whether it is benign or malignant, we have various options. So like tumor, even a good quality ultrasound with contrast when done, along with Doppler, it can identify vascularity within the thrombus, and that suggests that it's a tumor thrombus. Similarly, if the thrombus enhances on contrast enhanced CT scan, it's a tumor thrombus. MRI contrast also can show enhancement of the tumor thrombus. PET scan shows the hot spot in the thrombus if it is tumor. So features of the tumor thrombus is the thrombus is contiguous with the tumor. Neovascularity is seen within the tumor, within the thrombus. It enhances on our artery. It washes out on portal venous phase like tumor itself. Hot spot on FDG with a high SUV and confirmation by FNA. So extent of hepatectomy, in peripheral lesions, the hepatectomy will take care of the portal vein thrombosis. But in a thrombus which is present in the first order branch and the main branch, the option is to do hepatectomy and thrombectomy, or to do hepatectomy with en bloc resection of the portal vein and reconstruction. This is an extraordinarily major surgical undertaking and is associated with mortality. So the portal vein, when involved, the surgery is possible. But when main portal vein is involved, it may or may not be possible. Hepatic vein may or may not be possible. And when it extends into the atrium, the surgery is not an option. TACE and tear, they both can be used in presence of portal vein thrombosis. However, the tear is better because it reproduces less ischemic effect and may help to take care of the regression of the thrombus within the portal vein also. So whenever there is surgery is not the option and we are trying to identify the treatment option, that tear is preferred over TACE. So in presence of portal vein tumor thrombus, the higher morbidity and mortality if you try to do surgery. Inferior results compared to those who did not have portal vein tumor thrombus. However, those who survived surgery have better prognosis compared to those who did not undergo surgery. Now, ruptured HCC is the next category. The rupture commonly occurs from the peripheral tumor and a protruding tumor or surface tumors. And it stretches the capsule and there is rupture of the tumor and there is sudden hemoperitoneuria or acute abdominal pain. If not properly treated, it could be fatal. Emergency methods are embolization, hepatic artery ligation, suturing, packing, and resection. These are the various options depending on the center where the patient is, the expertise of the person, how stable patient is hemodynamically, and how major liver resection is necessary. So that will decide what primary treatment is done for this patient. Initially, arterial embolization to stop the bleeding and then later evaluate patient completely and then do the resection is a better policy. The survival of more than 40% at the end of 1 or 3 years is possible in spite of having a ruptured tumor. So it's not a gone case. So role of embolization for achieving homeostasis. Prognosis is not that bad. However, the suitability of the transplant is a questionable thing. So this is the patient who had a tumor which ruptured. It was tumor in segment 6. And there's a hemoperitoneuum we can see. The patient was stabilized with embolization and was later resected. Fibronemular HCC is a better variant of hepatocellular carcinoma. It's present in about 2 to 5% of the cases. Young age, no association with underlying liver disease, positive lymph nodes, more common on the left side, and less raised alpha-fetoprotein. These are the typical features of fibrolamellar HCC. Radiologically, there is a large mass which central scar. and the 5-year survival is better in these patients. So this is the CT scan of the fibrolamellar HCC. This is a large tumor with central scar, and that's because of the necrosis within the tumor and the scar. This is the MRI feature. This is the central scar. So better prognosis is because of the absence of underlying liver function, greater resectability, better histology. Those patients who are not resectable are also candidates for liver transplant. Neurotensin and transcobalamin are the tumor markers used. So in normal liver major resection, in child A cirrhosis, depending on the size, you have the extent of surgery. However, in child's B and C and multicentric tumors, transplant is an option. So liver transplant for HCC, a much talked about subject these days. And surgical resection and local ablation treatments are associated with very, very high incidence of recurrence because of the underlying pre-carcinogenic liver. And hence, rationale for liver transplant is it takes care of the multicentricity, underlying liver disease, as well as the carcinogenic factors. So it's a very reasonable treatment to do in a selected cases. But the downside, there is organ shortage already. Progression of the tumor while you are waiting for the cadaver organ. Cost compared to other modalities is very high. Availability is also an issue, and the less favorable results in case of a very large tumor. So the transplant is considered when it is a multicentric tumor, liver cancer in presence of underlying child cirrhosis, or very badly located tumor which is not amenable to other treatments. So these are the various, there are various selection criteria used by different centers. However, the first standard acceptable criteria were Milan criteria published in 1996, and they said that a single tumor less than 5 centimeters, 3 tumors all less than 3 centimeters, no vascular invasion, major vascular invasion, no extrahepatic disease can give survival as high as 75% after 4 to 5 years, and recurrence rate of only 8 to 15%. And hence, this was incorporated in most of the algorithms of treatment. Then the meta-analysis was done of few series and few papers who use Milan criteria, and they proved that Milan criteria is good at predicting lower microvascular invasion rate, lower alpha fetoprotein levels, and lower incidence of the microsatellites. However, the imaging techniques underestimated some cases, and some patients who were operated beyond Milan criteria showed good result, and hence there was a thought of expanding criteria and try to offer the advantage of liver transplant to more and more patients who did not fit for Milan criteria, and hence the more extended criteria came into the picture. The most widely used criteria these days is the UCSF criteria, where the single tumor less than 6.5 centimeters, 3 nodules, none less than more than 4.5 centimeters, total tumor burden less than 8 centimeters. Again, no vascular invasion, extrahepatic spray is most important, and that also got an excellent good outcome at the end of 1 and 5 years and less recurrence rate. This is another BCLC criteria, and these are another criteria, ASAN criteria and all. So different criteria came into picture. Most commonly used are the UCSF criteria and almost DDLT centers. However, in LDLT centers, people have used extended criteria beyond UCSF also to give advantage of transplant to patients who have larger tumors. So when the different scoring system or the criteria were compared, the Milan criteria had slightly better result compared to UCSF criteria, and both of them are much better compared to those who have beyond UCSF used. So LDLT is a completely different ball game. It's a dedicated graph for that particular patient. By offering transplant to that patient by an experienced center is not putting any other patient at a disadvantage by not giving them liver. And hence, if a carefully selected patient in an experienced center, LDLT has been used for slightly bigger tumor and extensive tumor in some centers. When you compare LDLT and DDLT, better survival and lower recurrence in LDLT because there is no weight. However, there is added donor morbidity in these cases. So living donor liver transplant is a very good option in a center where waiting time is more and the expertise is good and the donor risk is less. In that case, living donor liver transplant is a very good option. The problem with liver transplant is there is a progression of the tumor while you are waiting for the transplant, and this can add to vascular invasion or even metastasis. And to take care of this, there are various treatment modalities which I'm going to talk about later. These are called liver-directed therapies. They are used to keep the tumor under control while the patient is waiting on the waiting list. Even the advanced SCCs in living donor setup are at times offered liver transplant following downstage. So first downstaging, then transplant. And this is individual centers policy. And in our center, we use UCSF criteria and we don't offer transplant to patients beyond UCSF criteria. Downstaging of HCC is either with the use of TARE or other liver-directed therapies. Resection before transplant. This is I'm mentioning just for the sake of completion. It is not commonly done. However, it was tried by a few centers in past. Not commonly done these days because there are now other liver-directed therapy options available. So when you compare primary transplant versus salvage transplant is initially liver resection is done, and when the liver tumor recurs, you do the transplant. So when you compare primary transplant versus salvage transplant, obviously primary transplant has better result. Only 1/3 of the patients are suitable for salvage transplant. So when you compare patients of primary liver transplant with liver resection and primary liver transplant with salvage liver transplant, in both the cases, results are better with primary liver transplant in selected cases. Poor prognosis is suspected in a patient of where the transplant is offered, where the upfront resection was done or the microvascular tumor invasion was seen in that resection specimen, or there was a presence of a satellite nodule. A patient who has undergone liver transplant for HCC, how do you do the surveillance after the transplant? The alpha-fetoprotein levels should be monitored every 3 monthly for 2 years and then 6 monthly afterwards. Rising alpha-fetoprotein should merit further imaging of the liver. Retransplant is a very difficult proposition and not very commonly used. So now there are centers who are trying to develop a model where all these factors are also included and better criteria are put into the practice and incorporated in guidelines to identify better patients who would benefit from transplant more. So these are the cases. This is a large patient. This is a tumor in the central part of the liver, cirrhotic liver, and this patient had transplant. This is a large tumor in otherwise normal looking liver. The vessel was involved and transplant was done. Or this is the photo which I have borrowed from somebody. This is a liver transplant. This is a cirrhotic liver and this is a multicentric tumor scene. This is another case cirrhosis with liver tumor. And this is the result after transplant, another patient. Now, liver-directed therapies is very important these days and offers good palliation and good uh, uh, symptomatic relief to a lot of patients these days. The percutaneous injection, which was used in good old days, is not so commonly used these days because it is replaced by radiofrequency ablation more or less. So radiofrequency ablation uses these special kinds of needles, which is inserted into the liver, either in the sonography or the CT scan guidance. Once the needle is placed properly, it is open, the umbrella is open, and then the radiofrequency generator is used to ablate the tumor. So this is the pre-ablation appearance of the tumor, and this is after ablation. So not only the tumor, but the part of the liver which you would otherwise resect beyond tumor is also ablated. So in such small tumors, radiofrequency ablation has a very good result. So radiofrequency ablation is used in child's stage A and B. In a small tumors, in larger tumors, you need to do multiple passes. However, as the size of the tumor increases, the result becomes less good. New methods allow larger lesions to be ablated. When you are withdrawing the needle, even the tract is ablated. So if there is tumor seedling, it is also taken care of. 3-year survival of as high as 80 to 90% in small tumor has been reported. There are other ablation methods like cryoablation, microwave ablation, ultrasound ablations. They all are there, but they have restricted use because they are available in very small number of centers. Availability is an issue. No much advantage over radiofrequency ablation. Radiofrequency ablation is widely available, is cost effective, and confers very good results with very less morbidity. And hence, most of these other ablation methods have largely been replaced by radiofrequency ablation these days. So here you can see as the size of the tumor increases, when you compare surgery and radiofrequency ablation, as the size of the tumor increases, the difference in the result between surgery and radiofrequency ablation becomes wider and wider. So this is overall survival and this is disease-free survival. So here you can see in a small tumor, surgery and radiofrequency ablations are more or less same. But as the size increases, the surgery has better option to offer and better result, overall survival as well as disease-free survival. Now, transarterial chemoembolization is intraarterial embolization of the lipidol and chemotherapy. The chemotherapeutic agent used is doxorubicin or cisplatin. It's a standard palliative care in BCLC intermediate stage patients. So large unresectable HCCs prior to liver transplant or radiofrequency ablation, this is at times used as a bridge therapy, and in large tumors for the palliation. So it is first line treatment for BCLC intermediate stage. Well preserved liver function is mandatory. No cancer related symptoms are if present, then the outcome is better. And significant major vascular invasion should be absent. If it is present, then as I said, radioembolization is better. So the recent advances allow TACE treatment both in early as well as large tumors. There are two techniques used for transarterial chemoembolization. One is conventional TACE, where lipidol is mixed with the chemotherapeutic agent and it is injected into the tumor, followed by embolization. However, now drug-eluting beads are available and they produce sustained release of the chemotherapeutic agents and at times produce better effect and better outcome. However, it is slightly more costly compared to conventional transarterial chemoembolization. So this was the patient who had a large tumor in presence of cirrhosis. Here you can see large spleen because of portal hypertension. This patient was waiting for transplant. So this is the right artery feeding vessel, and this is the tumor vessel, multiple vessels seen. This is the arteriogram. Now the lipiodol has been injected through this catheter, and this is lipiodol which is seen inside the tumor. And then the embolization is done, and now nothing is seen. And the same tumor after 4 weeks on CT scan. Now, after chemoembolization is done, the repeat CT scan is done after about 6 weeks or so, and repeat CT scan and tumor markers along with patient's clinical conditions and liver function tests will decide whether patient has a tumor response or not, what is the extent of tumor response, how much is the reduction in the alpha fetoprotein, how much is the reduction in the vascularity, and if there is neovascularization that develops in future, or there is a residual part of the tumor which needs to be addressed, then the repeat procedure is possible, and tests can be repeated. Transarterial radioembolization is the intraarterial administration of the microsphere which are labeled with radioactive substance. Now, commonly used radioactive substances are yttrium-90, iodine-131, and rhenium-188. So these are the commonly used ones. The yttrium-90 is the one which is famous these days. Now, these microspheres are of two types which are available in the market. One is glass-made theraspheres and resin-made spheres. Now, glass sphere produces less embolic effect, and hence in presence of portal vein tumor thrombus, it is the glass sphere, which is therasphere, which is preferable, while the resin made sphere is more embolic and should be avoided in presence of vascular invasion. So these are the various indications and situations where yttrium-90 is used. That is in case of the large multifocal tumors, bridging therapy, tumor downstaging, and candidates who are not for surgery. There are reports and there are situations where people have used iodine 131 in an adjuvant setting, but it is not commonly or regularly used by all centers. Now, once a tear is done, there are various criteria called RECIST criteria or WHO criteria, which are used to see the response. Like tear, like TACE, tear can also be repeated. So what are the results? Complete response in about 3 to 5% of the cases, partial response in about 30-40% of the cases, disease remains stable because of tear in about 50% of the cases, progression during or after treatment within a short time in about 6 to 10% of the cases. Tumor progression after tear is usually after 10 months in most cases, and median survival of about 16 months has been reported in large studies. So what are the toxicity apart from the post-embolization syndrome, which we can see in TACE and tear? So in tear specifically, lung and visceral toxicity can occur because of the systemic effect of this radionuclide substance that we use. The common side effect is a transient fatigue syndrome, which subsides on its own. So tear can be used for tumor with both the sides, bilobar disease, unilobar disease, or even subsegmental disease. Special catheters are used, and this is how the microsphere go to the tumor. So it's a very good treatment, little costly, but very effective. Various trials have been there to compare TACE and tear. Certes, Mains, and Premier are the common and most widely quoted trials. So in these trials, the overall survival, progression-free survival, progression rates, and disease control rates were more or less same in TACE and TARE. However, more patients underwent transplant and were downstage with TARE compared to TACE. And TARE is better in presence of portal vein tumor thrombus. Okay, so again, this is a slide which says the same thing, that the TARE is better for portal vein tumor thrombus. When you compare surgery versus TACE, so for BCLC stage A, surgery is the treatment of choice. For stage B, chemoembolization is the treatment choice. However, in selected cases of stage B, you can have good result with surgery, but you have to select the patients rightly to avoid morbidity associated with underlying liver disease. Radiotherapy has not been the case used for hepatocellular carcinoma treatment for many, many years. And hence, when this BCLC was published in 2000, radiotherapy was not included in it. However, a lot of progress has been made in technology in last few years. And now, because of the availability of SBRT, high dose radiation with the protection of the surrounding liver parenchyma is possible. And hence, now in NCC and SBRT has been included. So it can be either used as an alternative to other liver-directed therapy or in combination with other therapies. So this is the tumor which was treated with SBRT, and this is after 6 weeks and this is after 4 months. So this is the very classical example how SBRT can be effective. So 40 to 50 grays are used in 3 to 5 fractions only. It is avoided in child's C patients. So large unresectable HCC, symptomatic portal vein tumor thrombosis, bridge to transplant, and part of combined modality treatment. These are the various indications where SBRT are used. However, every radiotherapy department cannot do this because it needs expertise, and you have to plan the treatment very methodically. Estimated 1 and 2 year survival after SBRT is about 76 and 57%. Predictor of overall survival is the number of treated lesions, performance status, pre-treatment liver function, and gender. Incidence of hepatic toxicity is 15 to 30%, and other non-hepatic toxicity, grade 1 is 16%, 2 and 3 are about 10%. So now HCC with extrahepatic metastasis. The most frequent sites of extrahepatic disease is lung, followed by bone, brain, and adrenal glands. Surgery is possible for isolated adrenal metastasis, and surgery is also possible in a small volume disease after many years of disease-free survival in lungs. Okay, so metastasis in adrenals and metastasis in lungs is amenable to surgery if the patients are selected properly. Independent predictors of prognosis is uncontrolled intrahepatic lesion, extent of vascular lesions, and performance status. Systemic therapy. Sorafenib is the most commonly used systemic therapy these days. It's a tyrosine kinase inhibitor. It has definite survival advantage compared to placebo by a few months. However, if used for a few months in a row, there is a possibility of development of resistance to sorafenib, and 20 to 40% of the cases experience minor to moderate adverse effects in terms of diarrhea, fatigue, or hand, foot, skin reactions. So it's a first-line therapy for unresectable HCC. in BCLC stage C patients. Routine use of sorafenib in patients with underlying liver dysfunction is not recommended because it can worsen liver function. So this is the kind of a patient who has otherwise liver function good can be given sorafenib because there is nothing else we can do in those patients. Phase 3 SHARP trial proved that there is, compared to placebo, there is definitely prolonged overall survival if you give sorafenib. Then sorafenib was also studied in combination versus monotherapy using erlotinib and doxorubicin in a trials SORADOX and SURGE trial. However, they failed to meet their primary effective endpoints while comparing monotherapy versus combination therapy. These are the various systemic treatments available these days, and out of all these options, sorafenib and lenvatinib are the ones which are now for first line treatment, and regorafenib and these other modality treatment including immunotherapy are for second line and third line treatment. All have shown extended overall patient survival and appearance to for the reasonable safety profile. So multiple trials are ongoing and a combination of the treatment is also being studied, and soon probably we'll have some more light on the choice of therapy, timing of therapy, sequence of the agents used, and the combination of the agents and the dosage used. There is a concept of developing shift to the left. That means at present, according to BCLC staging, sorafenib is used here only. However, in adjuvant setting or in earlier disease, before the disease becomes very advanced, earlier use of sorafenib is also being tried by a few centers. It's known as the shift to the left. So if we talk about this various clinical situations, so what did we do? So solitary lesion is a normal lesion, normal liver, sorry. It's resection. Solitary lesion, a well-compensated cirrhosis, again resection. Ill-located tumor, either liver transplant or SBRT. Then multiple liver lesions or decompensated cirrhosis, again liver transplant. While waiting, liver-directed therapies. If the patient has metastatic disease, then sorafenib or other similar systemic therapy. Medically unfit patient, glucoregional or only supportive therapy is used. So in summary, I would say that depending on the underlying liver function and extent of tumor, the patients are staged. Most commonly used is BCLC staging, and depending on the stage, the various treatment options are offered to the patients. This is very well received these days, that all the modalities have their own specific place in the treatment algorithm. And if used judiciously by selecting right patient and offering right treatment to right patient, we can have very good long-term survival in these patients. Treatment is very important, but at the same time, early detection by screening and prevention of this disease by preventing diseases like hepatitis B and C, we can deal with HCC and make it a less fatal disease. Thank you very much.
Thank you, Dr. Chirag Desai, for the wonderful presentation. You demystified most of the mysteries of HCC. Now, over to the moderator. Before that, let me acknowledge some of the stalwarts who are logged in: Dr. Neelamegam, Dr. H. Ramesh, Dr. Sudhi from Amrita, Dr. Subramanian Rao, Dr. Sadashivam, Dr. P.K. Reddy, Madhu Murali from RCC, Dr. Sudhi from Amrita. A lot of people are logged in. we will come to them. Before that, the moderator is requested to present his slides and then moderate whatever there in the chat box.
Thank you, Dr. Chirag, for such a wonderful presentation. And let's see some of the slides which we have. So at our own center, we are talking about LDLT at Sir Gangaram Hospital. We have performed more than 1,000 transplants till date, and in the data which we had looked from 2009 till 2017, about 71 transplants were done for HCC with a mean age of 53 years and male to female ratio of 6:1, with a median follow-up of 814 days. 45 patients were within Milan, 26 were outside Milan. And as already described by our speaker, the survival is much better, which was seen within Milan as compared to the outside Milan. So just wanted to, since we are going to show the video of laparoscopic liver resection, the first laparoscopic anatomical liver resection was done in 1996, and the first attempted was a left lateral sectionectomy. So ideally, you can go ahead with this type of intervention if it is a small or a focal or a localized tumor on the anterolateral segments. There is, in some cases, you may need of intraoperative ultrasound. There are two ways of doing this. Either you can do a laparoscopic assisted hepatectomy, or you can perform a total laparoscopic liver section if expertise is available. So I think the photographs for some reason haven't come on these slides. So let's just straight away go for the video. Is the video visible?
Yeah, it's visible.
Yes. So we initially, after putting the ports, I wanted to show the sides of the port, but for some reason it is not seen on the slides. We'll try and come back to it a little later if possible. So we take down the falciform ligament first. Obviously, you have already done the laparoscopic diagnostic lab, seen if there are no metastases and whether the tumor is amenable to surgical resection. Once that is done, you start mobilizing and continue doing your liver transaction. This patient was a 55-year-old gentleman who had a lap chole done about 15 years ago. So there are some adhesions at the gallbladder fossa, which are being separated. This was a large solitary lesion, which was on the left lateral segment 2 and 3. So hence we thought it was amenable for a left lateral sectionectomy, and we performed this with laparoscopic approach. Now we wanted to pull the liver up and open it like a book. The technique remains the same as you would do in the open method. You need to open it like a book. So the traction given here, on one side, we place the proline suture and gave the traction through the anterior abdominal wall. The suture is being pulled out. And the other side, the falciform ligament, you try and hold that and pull on the opposite side. That way you will get traction and the liver will start opening like a book. Now we are using the laparoscopic CUSA, and with help of laparoscopic CUSA with ligature, you can use harmonic as well, or any energy device which you are comfortable with or which is available at your center. You can use that. And any vessel which you think are more than 3 millimeter, I normally would prefer clipping them and then cutting it. We can also use the way we would do a liver resection in an open method. There is use of CUSA with a bipolar. So here we have access to laparoscopic bipolar as well. So CUSA with bipolar, CUSA with either a ligature or a harmonic can also be useful. Certain times you can end up going into a vessel. What you need to do is try and insert a gauze and try to keep the gauze there for some time and try and tackle the vessel either with ligature if it is small. If it is a large vessel, you may want to place your sutures. Again, we have put a gauze and given a good wash to get proper visibility. There we are now trying to separate the left lateral pedicle with the help of CUSA. The smaller tissues above it are being now taken down with ligashore. We are now able to go through the left lateral pedicle. Once that is done, we apply a vascular stapler across the pedicle. Once that is done, you continue, the traction can be increased, and you can continue your dissection again further with laparoscopic CUSA. Smaller fibrous strands can be cut with either bipolar or an energy device, but any larger vessels you come across, you can either clip it, or here we have, in this case, we have placed a hemolog. When you come across a large vein, a hemolog would be preferable rather than just a small clip. Or here you can use a vascular stapler on the hepatic vein. In this case, we preferred putting a hemolog stitch. So this is applied to the site which is being now preserved. Doubly clipped. And then cut. Again, there is a small vessel which we can see coming across. Clip and then cut. So we finished the left lateral lobe transection almost. Once that is done, only then we try to dissect and remove the left triangular ligament. So the transection is now complete. And now the attachment of left triangular ligament is being taken down. That's the cut surface being seen. And to remove the liver, we take a small phalansteal incision. The specimen is now being retrieved through the small phalansteal incision. Thank you for watching this video. And I the slides back, so sorry, but just wanted to add certain things. The pictures are not seen again here. So anyway, let's go to the question answers session. There are a lot of questions which have come, and we would like to take each one of them one by one. So there are some questions, Dr. SENADHIPAN. Unfortunately, I'm not able to see them in my chat box. Will you be able to?
Yeah. That should be there because anyway. There are logins from Pakistan. There are logins from Jeddah. Abdullah Befaraj, Ismail Ibrahim from South Africa. Srivastava. First question is bone scan routine evaluation or only if AFP is high or bone pain is there?
So Dr. Chirag, you want to take that question, please?
Yes, I do in all patients.
Yeah, bone scan is a routine in your patient, is it?
So what we do is bone scan is actually required in most of the cases because you need to identify either a bone scan or a PET scan whether the patient has got any bony metastasis. So if the patient has got metastasis, your plan of treatment may change, and hence it is preferable if you are able to do bone scan pre-op. If you are planning any surgery, then bone scan should be done pre-operatively, as well as you need to also do a chest CT scan because the chest metastasis and bone metastasis are possible in an HCC, so your treatment plan may change.
And alpha fetoprotein is very misleading. It could be normal in large tumor and very high in very small tumor.
Actually, what is the role of alpha fetoprotein if the alpha fetoprotein is normal preoperatively?
No, it has a prognostic value also. See,
no, if it is normal preoperatively, how will you evaluate?
It doesn't mean anything. Basically, we are not going to decide anything based only on alpha fetoprotein. We do good imaging and two types of good imaging with classical features. Then you go ahead and do the surgery. If they are not high, then they will not be helpful post-operatively. But if the alpha fetoprotein was high initially, then it is good to repeat them on follow-up and then decide whether it falls down, whether there is residual disease or not, or whether there is recurrence or metastasis. So it helps when it was high, but if it is not high, it does not rule out the possibility of cancer.
Yeah, there is a question regarding role of biopsy in case of HCC in non-cirrhotic liver.
Biopsy is usually done where the either non-operative treatment is done, palliative care is done, or the diagnosis is equivocal or uncertain on classical imaging modalities. But if the diagnosis is certain, the features are classical on imaging modality, then there is no need to do biopsy. Now, biopsy of the tumor and biopsy of the normal liver, these are two different things. You may not do biopsy of the liver, but if you are planning larger resection, you want to know what is the characteristic of the residual liver. And if you are bothered, then you may do the biopsy of the liver, which is going to stay back in the body. But incidence of that has gone down because of the availability of elastography and all, and you know the characteristic of this liver before and through non-invasive methods.
The next comment is from Dr. H. Ramesh from Lakeshore Hospital, Cochin in Kerala. We would appreciate if data is also indicated the source. For example, anatomic versus non-anatomic research, because you have not shown the data. He's telling to elaborate the data, the reference from. And also he says liver resection, the difference between peripheral and central lesions and what the tumor-free liver remnant is. For example, if a right lobe of tumor pretty much fills the right lobe, then the tumor-free function liver remnant is better and resection is on. On the other hand, a small tumor deep in the liver will require a large amount of liver resection with a higher chance of postoperative liver decompensation.
Now we agree with all the comments, yes. Thank you.
I think Sudhi is there in the audience. Sudhi, can you please unmute your mic?
Oh, hi.
Hi, Sudhi.
Hi.
Hello, Sudhi.
Yeah. Can you please?
Hi, Chirag. Hi, thank you.
Inputs.
Thank you for that wonderful lecture and the video, Chirag. And so basically, a couple of questions actually. One was you talked about the role of biopsy when you're planning palliative treatment, and again the diagnosis of HCC by European criteria. And I think both those have actually been almost been superseded by the ASLD criteria, where they've said, you need only one radiological imaging as long as it is LIRAD 5. And again, that is enough even for palliative treatment. You don't actually need a biopsy. So we can actually go ahead with that. With the LIRAD 5 lesion, you can carry on even palliative treatment without biopsy. That was one comment. Second, your mention of TARE as a treatment modality, which is probably better than DAYS. But two recent large randomized controlled trials, almost 460 patient one trial and 360 in the other trial, SERA trial and Cervinib trial, which you must be knowing. Both those have shown that there is absolutely no, that both were comparing radioembolization with sorafenib. And both, they're actually non-inferiority trials, but both of them didn't show any benefit at all for radioembolization compared to sorafenib, because the median survival is something like 10 months. So we have more or less given up TARE. If we can't do anything, we prefer SBRT than TARE, particularly given that the expense is so much for these.
That's true.
So, I mean, the biopsy, I mean, do we need biopsy if we're actually going for palliative therapy?
So you prefer SBRT over TARE?
Yeah, we do.
Okay. Sorry, what were you asking?
No, the biopsy for palliative treatment and the need for 2 radiological imaging, does it still stand, or is that?
No, if it is LIRAD 5, that's fine.
Okay, it's fine. Yeah, okay.
But if it is LIRAD 3 or 4, then probably you would like to add either MRI or biopsy.
Okay.
Because our oncologists are at times still not very comfortable to go ahead and do things if they have no proof and all those things. Though this problem has reduced significantly these days, but you have all types of people you deal with, so you have to at times deviate from what is ideal.
Yeah. And Naimish, thanks for that video. It's a fantastic video. But nowadays we are going into robotic these days. So
we'll be having a session on robotic donor hepatectomy by Sudhi. That will be somewhere in November.
Okay. Look forward to that. Okay.
Yeah. Another question from the floor is that name to headache. How do you prevent PHLF? Do you use prediction score? What is the percentage of PHLF in your department?
The PHLF, if you select your patients correctly, then the incidence is not very high. Basically, the underlying liver function, pre-op assessments, and extent of surgery that you decide, the type of surgery you do, the amount of blood flow, and what kind of inflow occlusion you use and all. See, these all things together decide what happens to the patient afterwards. The rate in our department is about 5%, you would say. And most of the patients from OT, they go straight to the ward. Only occasionally they are shifted to ICU for monitoring. And the serial liver function tests are done to monitor them. And if occasionally you may have to intervene. But in most cases, the post-operative course is what you have predicted in the preoperative part.
Yeah. A question from HTM is Cochin. Do you use indocyanine green or any other functional indices?
No, we don't have facility available for indocyanine green, but it's a very good modality treatment, which is available in more and more centers. It's basically, there are various techniques used to identify lesions otherwise not identified, to decide the extent of the tumor, to decide the line of demarcation. For all these things, it is very important. And the timing of the injection of the dye is also very important, depending on the outcome you want from that. But we don't have that facility in our department. And but I'm aware that it's available in more and more departments, and probably it may become the common things in years to come.
Yeah. Dr. Sandeep Chandrasekhar wanted to know, do you use CT volumetry or any special software like Meridian?
No, we don't use any other software. our radiologist uses their own integrated software, and they calculate the total liver volume, tumor volume, and the part to be removed, and the residual liver volume. We don't use special software.
And how do you assess the cirrhosis preoperatively?
Cirrhosis, presence or absence of cirrhosis is evident from the blood test, from the imaging, and what extent of varices patient has, features of portal hypertension and all those things. However, good radiological imaging is very good at identifying features of cirrhosis. It just means if there is atrophy, hypertrophy, there is choroidal hypertrophy, presence of collaterals, ascites, large spleen. So all these things are direct and indirect ways of identifying presence of cirrhosis. And obviously, the child pug score will tell you the extent of cirrhosis and the functional result.
Dr. Gurudatt, what I wanted to know, as a part of bridging therapy or in order to downstage the tumor for transplant, how do you decide which loco-regional therapy you want to use?
See, downstaging or treatment while waiting?
For transplant.
Okay. See, there are two different issues. Whether we are talking about just the treatment while you are waiting for transplant, then the small lesions don't need anything done. You just do the serial scans, keep an eye on them. The large lesions are dealt with by chemoembolization, and they are kept under control. In some centers, people use also SBRT. If there is presence of tumor vein thrombosis, then portal vein tumor thrombosis, then some centers use TARE to take care of that. However, we most commonly use either just observation or chemoembolization.
Before going to the next question, I request Dr. Thomas Varghese to unmute his audio and open his video. Dr. Thomas Varghese? Yeah. Please give your input, sir. You will have to unmute.
Yeah, is it okay? Am I audible?
Yeah, audible.
Yeah, it was a fabulous presentation, definitely, because only selected centers are now into liver transplants in cancers. The question and the problem is that the limiting factor is cirrhosis or cirrhotic liver. But majority of the liver tumors, hepatocellular CS, except fibrolamellar type, are all cirrhotic. So how do you select a patient who is cirrhotic yet a candidate possible, like tumor size for hepatic resection or further management? So cirrhosis is a common feature.
Yeah, so if patient's child status is child A, very well compensated cirrhosis, and easily resectable tumor, not requiring very major hepatectomy, the tumor is not too deep down, the vascular invasion is not there, then probably the resection is a better option, because this patient can do without transplant for quite some time. But if the child status is B or C, or the tumor is multicentric, or the tumor is large, or tumor is located very close to the pedicle, so these are the cases who are better off with transplant in terms of long-term survival and the postoperative recovery.
So in your center, my last question, in your center, you are preferring living donor transplant or cadaver transplants?
We have a mixed program, LDLT and cadaver program, the majority cadaver. And most of, in our Gujarat SOTO, we are not allowed to register patients beyond Milan criteria. But for LDLT, we used UCSF criteria, up to UCSF criteria.
Because the acceptance of cadaver donation, organ donation is popular in Gujarat, or it is having biases?
It is popular, but the organ sharing is not as good as South. but it
Yeah,
is
because what we understand in many of the religious considerations come before human considerations.
Yeah.
So in permitting donor,
it is very common in Gujarat.
yeah. Because I was in Tata Memorial, I know what is the culture in neighboring states around Maharashtra, our northern part. I don't think that in South Kerala it is so much great, but still, I think more wider acceptance nowadays
Yes.
for cadaver transplants. Anyway, it was a very good show. Congratulations to all the presenters as well as Baiju for this online teaching courses. Excellent.
Thank you.
Good luck.
Thank you, sir.
Good luck. Good luck.
Let me go to the next question. In a child A cirrhosis, what is the threshold of tumor size for resection versus transplant?
It is not the size of the tumor, it is the size as well as the location. But if it is tumor located in such a way that the anatomical resection is possible with good residual liver, then the resection is the first choice in child's cirrhotic.
Yeah. Dr. Mehta has asked a technical question. Do you use a specific clip applicator for the liver resection?
Yes, so thank you, Dr. SENADHIPAN. I'll take over because I'm able to see, since the app had crashed, so now I'm able to see all the chat questions.
Yeah,
so,
please.
So the
And the next question is by Rashesh Solanki to you, to
yes.
Dr. Mehta.
I saw that. So now what we do is our laparoscopic clip applicators are available, which are long in length, and that is what we use for application of the clips. Again, there was a similar technical question put to us again, whether do I ligate the pedicle amas or do we separate the vessels for laparoscopic liver resection? Now, since this was a separate laparoscopic left lateral lobe resection, we had applied the stapler amas. But if you are doing a major lobe resection, either the right lobe or the left lobe, you should ideally separate out the vessels, because if you take them together as a pedicle, there is a chance that there can be arterioportal fistulization, or if you take it with the bile duct, then it can, in some cases, as anecdotal cases we have heard, that it can communicate to the biliary system as well. So preferably, if you're doing a major lobe resection, you should ligate the vessels separately. The next question we have from, the name is not written, but it's Galaxy M30. What is the importance of Hong Kong liver cancer staging? Dr. Chirag, would you enlighten us on that, please?
See, as I said, there are too many different staging, and there are so many staging systems because there is a heterogeneous way of presentation in East and West, and that's why different countries use different staging. So Hong Kong uses Hong Kong staging because of their local scenario and local logistic, but it is not used by many centers widely. So most widely used one is the BCLC one, and TNM staging, which was used before, is not very popular now because only 20% of the tumors ultimately get operated. Unless you have a surgical specimen, you won't have a full TNM available. So that's why TNM lost its popularity. So Hong Kong staging is not used commonly. Yeah.
The next question we have from Dr. Rajiv Maharaj. He has put up a question. You have a child B cirrhotic, ECOG 1 status, 4 centimeter tumor in segment 5 and segment 8. There is no evidence of extrahepatic spread with an alpha fetoprotein of 600. What would you plan on such a patient?
See, 600 is a very high alpha fetoprotein. Alpha fetoprotein usually is raised in undifferentiated or poorly differentiated or less differentiated tumors. And the level of alpha fetoprotein here suggests that this tumor biology is very bad. So though only 2 tumors are seen, there may be more tumors. So though this patient does not have any other curative option available other than transplant, to go ahead straight away for transplant is not a very good option. Even patient has a living donor available. So I would like to treat this patient with liver-directed therapy, and which therapy, that depends on the center, and see what happens to this tumor in next 3 months, what happens to the tumor markers. whether new tumors comes up or not, and how this patient overall tolerates all these things. If the next 3 months are fine, the tumor marker comes down, disease remains stable, no tumors appear, no extrahepatic disease present, and then, okay, it's a good idea to go ahead and do the transplant. Because even in living donor liver transplant, where the graft is dedicated to the patient, there is a significant donor morbidity involved, and we cannot take it lightly if the patient's benefit is going to be borderline. So
What Dr. Chirag
my comfort level is 500 alpha fetoprotein.
So what he's trying to convey, what Dr. Chirag is trying to convey is that the alpha fetoprotein level of more than 400 has got a higher risk of recurrence, and he would downstage this tumor first and see the biology of this tumor. So the 3 months time period which he's talking about, he's asking you to wait and look at the biology of the tumor. And if in 3 months time a patient has not presented with anything extra hepatic metastasis, then in these cases you may plan to go ahead with liver transplantation. Next question is from Adianto Nugroho, who is asking again the question on ICG. We have actually discussed about the ICG clearance. Dr. Chirag has already answered that there are certain centers which have got ICG options available, and routinely now more and more centers have started using ICG to identify the tumor. And in some cases, it can also help you. What Dr. Sudhi has also mentioned, that as a negative contrast, you can use ICG as to assessment of your resection margin. And I think if ICG, once it gets widely available to more centers, more and more centers, then ICG will eventually become a norm or a standard operating procedure in most of the liver resection cases. Next question is from Dr. Sharad Desai, who says there are huge masses of right lobe tumor which is more than 15 centimeter. Would you prefer to open the chest or thorax in these cases? Dr. Chirag.
If it's a large mass, obviously that is one of the options, but my preference would be to open the abdomen rather than just the hockey shape incision. Then in that case, for better exposure, I may change the incision on the abdomen, either inverted T or Mercedes-Benz incision. And in such large tumors, I use the anterior approach. Bel-Geddes anterior approach is very good for such situation. And you divide the liver first and then mobilize it from the diaphragm. In that case, there is no torque at the hilum. At the same time, there is no rupture of the tumor, no possibility of avulsion of the hepatic vein, and the access to the hepatic vein, which is very difficult otherwise, is not the case. So these large tumors are always not a bad sign. Some of these tumors, because they are single, otherwise in a non-cirrhotic liver, they are probably ones who may behave eventually better in a long term. But you have to address them separately. Thoracoabdominal, I will not use. I would use a different type of incision, wider incision on abdomen side, and do anterior approach.
So Dr. Desai, most of the surgeons would not actually prefer doing a thoracic approach or adding it, because that would increase the morbidity of the patient. And as Dr. Chirag has rightly pointed out, you can actually approach with an anterior method. Do not try to mobilize the right lobe of the liver, because in a large mass, you may not be able to mobilize the right lobe. So go in for the anterior approach, tackle the pedicle as well as the right hepatic vein, and then separate the mass from the diaphragm. The next question is, in case of HCV, would you treat these patients with antiviral before LDLT or after LDLT?
I think I would start with antiviral treatment while they are waiting for a transplant. And it has no adverse effect. It does not worsen patient's condition, and it is better to control the virus.
So anti-HCV treatment has come for since a long time now, and now it has become a standard procedure that you treat patients pre-operatively with the therapy which you are available, because some cases which are even decompensated cirrhotics in Hep C can actually become well compensated, and you may be able to manage these patients without liver transplantation Hence, treatment with the therapy before LDLT is what is advisable. However, in cases which have got severe decompensation and you have to go in for transplant on an emergency basis, then in these cases, you would prefer starting treatment post transplantation. The next question is from Dr. Sarath Desai again. Since non-anatomical resection also gives good result, can we ligate the vessels intrahepatic, thus avoid opening up the hepatic plate? Dr. Chirag?
Yeah, certainly that is also an option. But as I showed you in my slides, if you do a segmental or anatomical resection, it has slightly superior results compared to non-anatomical resection. But when you do non-anatomical resection, obviously you'll end up ligating most of the vessels within parenchyma. But there also you have to have your gadgets ready if at all you may need to do the Pringles, because if there is sudden gush of blood, you may have to control it. It depends which size of the wedge you are talking about.
Next question we have from Dr. Sudhir Ovi. What extent of resection would be possible if endoscopy shows early varices in a child's ACLD? Survival advantage in downsizing by alternative management and resection. What would you prefer in these cases?
So in child's A patient, if there are early varices and if the lesion is peripheral, the peripheral resection is possible, and there is no need to downstage it. But if the lesion is large, then obviously you will need to control the lesion first, reduce the size, and then deal with it. Have I answered the question?
I think so, fair bit. And Dr. Sudhir has he does fair bit of robotic, and that's what we had discussed with Dr. Sudhindran as well.
Yes.
So the only difference between robotic liver resection and laparoscopic, the advantage of laparoscopic is it little cost effective. Not every center is able to afford like Dr. Sudhindran's center of robotic surgery, because there is a fixed cost which is added to every patient of the disposables as well, which is about 1 to 1.5 lakhs in every patient. And hence laparoscopic liver resection is still is an option which, if it is possible to go ahead with this type of resection, then some of the surgeons may carry on with this. The next question we have is from Sagar Pupala. The child's A or an early B with a 5 centimeter tumor, what is the advantage between, how will you decide between resection and transplant, and why would you select either of these two?
See, if the lesion is deep-seated and requires major resection, I would prefer transplant. If lesion is small and peripheral, amenable to surgery without morbidity, I will go for resection. And decision for transplant also needs consideration of cost, availability of donor, and the waiting period. So somebody who is borderline B should be selected for resection with very, very careful mind, because you don't want decompensation in the postoperative period.
So correct. So Dr. Sagar, also what we need to do is we need to find out what is the primary cause of cirrhosis. Most of the cases of Hep B, there is a higher chances of recurrence or a development of tumor. Even if you resect the tumor, the chances of recurrence of tumor is much higher. And as already shown by Dr. Chirag, the percentage of outcome or the survival outcome after a salvage liver transplant is inferior if you have done a primary liver transplantation. The next question is from Dr. Karthike. HCC with lymph nodes at hepatoduodenal ligament, would that be considered as an extrahepatic or a locoregional spread? And in these cases, what would you do? Would you go ahead with a tumor resection, or would you subject these patients to liver transplantation?
This is not very common, first. It is common in fibrolamellar HCC, the lymph nodal metastasis. And I would consider as a distant metastasis, and would not consider patient for transplant. What would you do, Naimish?
Yeah, so see, there are, again, Dr. Karthike, there are a lot of things in here. One is those patients who have got cirrhosis, there are a lot of nodes which are there. So these nodes are basically inflammatory nodes, or because so the periportal nodes are not exactly metastatic nodes. So in cases where you want to differentiate whether these are locoregional spread, what we have done is we have now started doing a PET scan on these patients. And if the lesion is PET positive and the node is also PET positive, and in those cases, though we had done transplant in the past, our experience has shown that there is a high chances of recurrence in these patients. So just by saying that lymph nodes are present does not mean that that would be metastatic. You would actually need to rule out. So we prefer doing a PET scan, and if the lesion and the nodes both are PET positive or PET avid, FDG avid, and then these cases ideally we would now not select and take for transplantation. The second part which he has also asked is tumor involving the bile duct with high bilirubin in a non-cirrhotic liver. Can it be taken up for surgery? And is there a size criteria for resection in a non-cirrhotic liver? These are two different questions, Dr. Chirag. First is, if the tumor is involving the bile duct causing obstructive jaundice in a non-cirrhotic liver, will you take up this patient for surgery?
It depends what is the level of, obviously, if it is causing jaundice in absence of cirrhosis, obviously it is blocking the main bile duct. Okay, it is not blocking one of the branches. So at times the large mass compressing the CVD also leads to development of the jaundice. So you have to see exactly what is causing jaundice, whether it is hemophilia, whether it is the tumor blocking the bile duct, whether it is the compression or infiltration. If it is compression and it is going to be relieved after removing the large mass, then go ahead with the surgery. And if you think that it is the involvement of the main bile duct, it is infiltrated and the lymph nodes are present, then it is not going to be the curative surgery. If it is hemophilia, then you control the bleeding, drain the bile duct, control the jaundice, and then go for the surgery.
So usually HCC do not actually invade into the bile duct. It is a rare phenomenon, though we have done 2 such cases where there is tumor going into the bile duct. Usually it does not directly infiltrate, but projects into the bile duct and causes actually a mechanical obstruction. So that is the cause of high bilirubin. Now, so you can go ahead with resection or you can go ahead with transplantation depending on the other criteria which are available.
And in non-cirrhotic liver, when you have such situation, you would also like to differentiate between intrahepatic cholangiocarcinoma and HCC.
Absolutely, absolutely. The next question Dr. Karthikeya has asked is there a size criteria for resection in a non-cirrhotic liver?
No, size is not a criteria.
So what is most important is what are you going to leave behind? It is always, when we talk about liver resection, it is the future liver remnant volume. And in a non-cirrhotic liver, you can get away with a minimum future liver remnant volume of 30%. So even if you are doing for a large size tumor, as we have already discussed before, you can go ahead safely with a liver resection in a non-cirrhotic liver with a future liver remnant volume rather than size of the tumor being important. The next question is from Dr. Shashank Agarwal. If FLR is not getting accordingly, then how to proceed? So I think he's trying to ask is if there is not enough FLR, what would you do if resection is the only option you are considering?
So see, FLR, that means you are going to do a major resection and you are leaving behind a small liver. So the only option that you have is portal vein embolization. But as I said in my presentation, cirrhosis, fibrosis, diabetes, male gender, these are the factors which affects the hypertrophy after portal vein embolization. So depending on how many of these factors are present, you can predict how much is going to be the rise in the FLR. So if you think that the patient is otherwise fit and the liver function is well preserved, then portal vein embolization, wait for a few weeks, repeat scan, see that the hypertrophy has occurred, and then go ahead and do the surgery.
So usually in a non-cirrhotic liver, it would increase in size, how the hypertrophy would be seen. In cirrhosis, the hypertrophy may not be as much as you would see in a non-cirrhotic liver. The next question is from Dr. Sagar again. He's asking me, how do you manage post-operative bile leak and vascular thrombosis post-operatively, and what is your experience? Now, Dr. Sagar, what we normally do is for any major liver resection, at the hilar plate, you need to suture. So the hilar plate is sutured with a absorbable suture material. We normally use Vicryl. You can use PDS if you are comfortable with that. And in a right or a left, which is a major hepatectomy, we have normally done a cholecystectomy with it. And through the cystic duct, I would normally insert an infant feeding tube, and after the surgery is over, try to flush with saline and methylene blue to check if there is any leak. So if at all there is leak, it would be from the cut surface. A small amount of leak usually would settle down. But if the leak is significant, then you might want to drain this leak. If you have not put a drain, then post-operatively, you might want to put a percutaneous ultrasound guided drain and drain that bile so that the patient does not go into sepsis. Regarding the vascular thrombosis, rarely we would see a vascular thrombosis post-liver resection. We have actually seen in one of the donors, post-donor hepatectomy, the patient had developed a portal vein thrombus. Patient was taken up. This was about 10 years ago. And the vascular thrombus was taken up. The portal vein thrombosis thrombectomy was done. Patient is still now doing pretty well. So that is our experience of bile duct leak and vascular thrombosis. The next question is from Shah Jahan. In liver transplantation, what is the chance of recurrence of HCC in retained diseased liver? Dr. Shahja, I am a bit confused here. When you said in liver transplant, what is the chances of recurrence of HCC in retained diseased liver? In liver transplantation, normally we would try to excise, remove the whole liver and implant. So that's an orthotopic liver transplantation. So the chances of recurrence here post liver transplant is completely different. So there is no diseased liver. What we are talking is probably what is the recurrence of HCC in a new liver. Dr. Chirag, you would like to say something on this?
See, recurrence can occur either in new liver or it could be outside liver. And the incidence of this depends on the initial stage of the patient and which criteria you use. If you use the within Milan, then the recurrence rate is about 8 to 15%. If you have used UCSF criteria, it is about 20% or less than that. But if you have gone beyond UCSF criteria, then the recurrence rate is very, very high. If you have used a patient, done the transplant in a patient who had portal vein tumor thrombus, then the recurrence rate is extremely high.
Dr. Sagar has asked the next question to Dr. Chirag. What is the FLR you would consider before going for a major liver resection?
See, major liver resection in a non-cirrhotic patient, 30% FLR I'm comfortable with. And if the fibrosis is there, 35%, and child's cirrhosis, 40%.
Right. Dr. Sunil Kumar has asked, what is the incidence of fibrolamellar and ruptured HCC in your experience, and how do you deal with it?
Ruptured HCC, we have treated only one case, and I've just shown it. The patient presented with acute abdomen, and on imaging, incidentally, patient was found to have tumor. So it was embolized, and the bleeding was stopped, and then patient was staged. And when patient settled down, then we did anatomical resection of segment 6 and 7. However, if you talk about fibrolamellar, the incidence is about 2 to 5% out of all the HCCs. And then you don't treat them differently. They are large, but they are still amenable to resection. The prognosis is better. And those fibrolamellar which are not suitable for resection, you consider that from transplant, and the criteria you use for transplant are like any other HCC patients.
Next question is from Dr. Yusuf Mustafa. In HCC and cholangiocarcinoma, would you proceed with liver transplantation? So I think he's asking about a mixed variety where there could be a mixed variant of HCC with a cholangiocarcinoma. Would you go ahead with liver transplantation in these cases?
No, I will not go about it.
So, but you would not know without doing a biopsy. We have actually done some of the cases where post-operatively we have found that it was a mixed variant, because when we send the liver for histopathology, that is the time we actually found out that this was a mixed variant with HCC with a cholangiocarcinoma. Is there any way you would find out pre-op, Dr. Chirag?
You do tumor markers CA19-9 also. So if alpha fetoprotein is also raised and alpha 19-9 is also raised, so that is a classic one or more indication to do the biopsy preoperatively and see whether there is this. And then if preoperatively I know, then I will not go ahead with transplant. But if it is the finding post-operatively, then you have already done the transplant.
You have already done it, correct.
But this patient will have probably inferior result compared to the person who had pure hepatocellular.
Pure HCC. True, true. Dr. Shahja has asked another scenario where a patient with child A, small, multiple bilobar liver lesions, and a alpha fetoprotein is low. What would you prefer, Dr. Chirag? Liver transplant, TACE, TARE?
I would do radiofrequency ablations.
Multifocal, small lesions, bilobar, bilobar, both lobes.
Both lobes, but if there are two on one side and one on one side, then I will do 3 radiofrequency ablation. But there are too many of them spreaded all over small lesions, then TARE is better.
Right. Now, what I would prefer is actually a different thing here with the child J, cirrhotic, multifocal, bilobar. I would actually prefer doing a liver transplant if the option of transplant is available with that patient.
Even if more than 3?
Yes, multifocal. More than 3 lesions, bilobar, and child is cirrhotic. So in cirrhosis, you would AFP, whether it is low, it is good sign, because a high AFP will there is a chance and indicates higher chances of recurrence post-operatively. But in these cases, the chances of recurrence would be less, and hence LT may be a good option if it is possible.
Then it has to be living donor.
Living donor liver transplant, absolutely.
Because this patient will not qualify for cadaver transplant.
Yes. So again, so there is a huge difference between the northern and the southern. So there is between the southern part of the country and northern part of the country, there is a huge diagonally opposite differences, where in northern part you don't get a cadaver that easily as you would see in the southern part of the country, and that in sometimes can actually logistically can make you decide whether to go ahead for LDLT or list this patient for a cadaver liver transplant. And hence a lot of things can be specific to the region where an individual is actually practicing. There's another question from Dr. Prashant Gupta. Should the specimen delivery be done in a bag after laparoscopic liver resection? What is the risk of seedling? So yes, you can do with, and ideally it should be done in a bag. Unfortunately, in our case where we had used the bag, the bag tore, and we had to remove just directly. So, but yes, answering your question, ideally you should use a retrieval bag which is available, and it is preferable to bring it in a bag.
Or you can use the gel port.
Yes. Dr. SENADHIPAN wants somebody else to come in, because I think we have exhausted the number of questions.
Dr. Subramanian Rao, Dr. People are there. Can you please open Dr. Subramanian Rao?
Yes. Bejo, once again, like last week, I don't do liver resections these days, but always good to learn from masters, because I keep teaching students. You have to continue as a general surgical oncologist, although you keep subspecializing. That is a problem for the seniors in the profession now, but that would vanish shortly. I think Chirag and Naimish, it was a wonderful session. You've been very patiently answering so many questions.
Thank you, sir.
I think Sunday evening has become a very important part of our weeks. It's become a very
Thank you for the comment.
It's not a weekend anymore. Most of the learning is happening, surgical learning is happening in the weekend, thanks to Baiju and his efforts. Great session.
Thank you so
enjoyed it.
Comments.
God bless.
Thank you.
Anybody wanted to ask directly, they can open their video and ask the speaker and the moderator. Actually, we entertain one-to-one interaction, though it is very late in the night. We entertain one-to-one interaction. Still, 86 people are there. Actually, almost 250 people logged in. We are expecting almost because it was streamed in YouTube Live and Facebook. Actually, almost 3 times the login in Zoom will be there. The usual audience is like that only. So we are expecting almost 750 to 80 in total. So they were watching you live. Yeah. Anybody wanted to ask any question? Please unmute your mic and ask question.
We have a question from Dr. Pramil
Chirag.
in the chat box.
Yeah.
Treatment of hepatic adenomatosis, bilobar hepatic adenomatosis.
Yeah.
Dr. Chirag.
Sorry, what is the question?
Treatment of bilobar hepatic adenomatosis.
I think I don't have an experience of this, so I don't know. It's very
Dr. Mehta.
Again, it is very, very unusual to have a bilobar hepatic adenomas, and it also depends on the amenability of surgical resection. So in these cases, you will be able to excise. If it is a safe resection is possible, then you may go ahead and resect. But again, this is a very arbitrary scenario which Dr. Pramil has pointed out. I have never seen a bilobar hepatic adenomas, but a unilobar, yes, you go ahead and resect. Any other questions we have coming up, please?
Yeah, Dr. Rudra, can you please unmute? Yeah, Rudra Acharya is an oncosurgeon from Delhi. Anybody else? Actually, then it is time to wind up. Thank you, Dr. Chirag Desai, for the wonderful presentation. It was really demystifying the HCC.
Thank you.
And Chirag and Dr. Mehta for the wonderful video and your presentation, and for moderating also. Thank you very much. Next week, we will be coming with the extraperitoneal space, the last frontier by George Dash. Till then, bye from SENADHIPAN Education Foundation. Thank you all. Thank you all the participants across the world who has participated. Thank you all once again. Thank you.
Thank you, Baiju, and thank you, SENADHIPAN Foundation, for the excellent opportunity. And I wish we stood to your expectation and
Yeah.
keep in touch. Yes.
Thank you.
Thank you. Thank you.
Thank you, Naimish.
Good night, all. Yeah.
Good night, all.